I know our listeners may be thinking, well, that sounds like a lot of needles or, catheter in the nose, but there are some completely non-invasive treatments as well. And the one in particular, I know you do quite frequently, I believe, in your offices, the transcranial magnetic stimulator. How do you guys use that for treating PTH?
That's a great question. And I'm actually seated in my TMS room. So you can't see the TMS machine that sits right behind me.
Yeah.
But quite a robust tool that we can use. In fact, let's see if I'm able to bring that a little closer. So transcranial magnetic stimulation. So we use a certain device with that delivers pulses of magnetic energy to certain parts of the central nervous system, usually the brain. The same device can be used for peripheral magnetic stimulation to reduce sensitization of peripheral nerves. So transcranial, when we use it in that transcranial manner, so different parts of the neural axis of the brain, and then we can use it for peripheral magnetic stimulation to stimulate nerves that are on overdrive, again, to try and help calm them down. So TMS. So quite a useful therapy. It's non-invasive, as you point out. So non-invasive, therefore, perhaps more accepted by a patient that prefers not to use medications, prefers not to have needles or catheters in the nostril or needles around the head, and they still have this affliction with a daily headache. So TMS has good research-backed data in its use in helping with these post-traumatic headaches. So a session typically lasts about 30 to 45 minutes, 10 back-to-back sessions, and even longer. So longer, up to 30 to 36 sessions. Quite a useful tool. And as the years go by, you start to see us as clinicians using TMS and what we call neuromodulation approaches. So approaches to control or to regulate dysfunctional neurons. It's not electroshock therapy, it's gentle pulses of magnetic energy to speak the language of neurons and to try and calm down these dysfunctional neurons that are on overdrive. So I like that you bring that up.
That was great. I always love talking to you because you're just such a wealth of information. Is there anything else, Dr. Mbeo, you want to talk about? Any additional things that came to mind? Or
I think we've gone through this topic pretty well, and certainly not in an exhaustive manner. We could talk for days about post-traumatic headache. I think a good place to begin, if one has that thought process, could what are the solutions? What are the options do I have? Speaking with a neurologist certainly will help shed light. Just as we've had this conversation, so many neurologists are aware of these tools